Hello everybody. I'm sorry I'm unable to be with you today to give this lecture in person, but I'm grateful for the organizers to give me an opportunity to present to you a brief talk on whole body MRI using a case-based approach. Here are my disclosures. We know that malignant bone disease is incredibly common, being seen in the vast majority of patients with multiple myeloma, but in the majority of patients with breast and prostate cancer also, with a high incidence in lung and kidney cancers. However, conventional imaging tools leads to poor confidence in knowing what the true clinical state of patients is. So, for example, we are unable to accurately predict who has metastatic disease, whether oligometastatic disease is present or whether polymetastatic disease is present, and this can have quite profound clinical consequences. Let me just show you an example of a 55-year-old man who has a low PSA 3.3 but is known to have a left-sided Gleason 9 prostate cancer, which you can see on this image. Now, if we stage this man, we can see that there is seminal vesicle invasion. We can identify a large tumor in the left side of the peripheral zone, and we can also see that there is T3A disease, and the AI engine also identifies a right apical Pirates 4 lesion as a second lesion, and you will see that there is a lesion anteriorly in the right pubic bone. So we have a locally advanced prostate cancer with likely bone metastasis. And this patient needs staging, and he undergoes a bone scan and a CT scan, which are shown here. Now you'll see that there are possibly 3 lesions on the bone scan, including this lesion here, which appears to be in the 7th rib, something here possibly, and in the right acetabular roof. So let's just have a look at that 7th rib, and here is the 7th rib coming along. Do we see a metastatic deposit? It's really quite difficult to tell. We can go up and down, but it seems like there might be some sclerosis there. If we then look at it on the multiplanar reconstruction, again we see some sclerosis, not very definite, and maybe the oblique plane would be helpful. And we look at the oblique plane and we see, yes, there is some endosteal sclerosis, which is consistent with a metastatic deposit. How about the lesion in the right acetabulum? Well, if we look at the right acetabulum, it's really quite difficult to see anything. Let's just magnify that up and see if we can see it more clearly. Again, really quite difficult. And then we'll go to the right pubic bone lesion, which was somewhere here. And again, really quite difficult to see if there is metastatic disease. So we have to answer a number of questions. Does he have bone metastases? And here are the zoomed up images. Is this oligometastatic disease, that's to say 3 to 5 deposits on the bone scan and on the CT scan? Should he have pelvic radiotherapy and long-term androgen deprivation therapy, which would be indicated for oligometastatic disease but not for polymetastatic disease? Should he have cyberknife radiotherapy to these 2 sites while his prostate is being treated, remembering that we can't even see the lesions very well on the scans? Or should we do next generation imaging to know what is going on, because it's certainly indicated according to the ASCO guidelines? And of course, we did a gallium PSMA PET CT, and you saw a lesion in the neck, which corresponds to this lesion, then another lesion in the lamina there, a lesion in the rib, and then another lesion in the transverse process coming up there. And then we begin to see the rib lesion. So here is the 7th rib metastasis on the right, an 8th rib lesion, sorry, on the left, an 8th rib lesion on the right. And then as we go down, maybe there is something in the spine there. And then as we go caudally, we begin to see these lesions, and that includes a lesion in the transverse process of L3, And then going further caudally, we'll see several bone deposits in both iliac bones on the right, on the left, then another lesion on the left side here. There it is. We see obturator lymph nodes, internal iliac lymph nodes, and we see this very large metastasis, which is invisible really on the CT scan. Finally, I think we see the seminal vesicle involvement here. We see the primary prostate cancer further down, and then we see the metastasis in the right side of the pubic bone. So this patient has polymetastatic disease. And if we look at the MRI scan on this at the same levels, we can see, for example, this lesion on the B800. Here's the fat fraction image. Similarly, we see the B800 here, the rib metastasis. But interestingly, this metastasis here, which was not called on the PSMA PET-CT, is in fact abnormal on the whole body MRI, and you can see it there on the fat fraction image. So we've got some clarity now on the state of his metastatic disease, 2 to 3 lesions on the bone scan. Not really sure how many lesions on the CT, maybe 1 lesion, but certainly polymetastatic disease on the PSMA PET-CT as well as on the whole body MRI. But have we progressed the patient in terms of a management plan? Should we take an active approach, which is pelvic radiotherapy and cyberknife radiotherapy to the 2 lesions that we can see on the conventional imaging, and leave the other lesions to be taken care of by ADT, because there is certainly evidence for that approach? Or should we take a palliative approach, given that this is polymetastatic disease, and treat him with androgen receptor directed therapy alone or even chemotherapy? And what you've now experienced is one of the problems with next generation imaging, which is stage migration. So patients you think don't have metastases turn out to have oligometastatic disease. People you think might have oligometastatic disease turn out to have polymetastatic disease. And this applies for any technology that is better than the bone scans. So let's talk a little bit further about the Will-Rogers phenomenon or the stage migration phenomenon. You'll know that on conventional imaging, we divide patients into non-metastatic and metastatic, and if you treat them, these are the survival curves. Now, within the non-metastatic state, there are some people with microscopic metastases or even indolent disease, which get reclassified into the metastatic group if we use next generation imaging. In other words, the false negatives move into this direction, but in here we'll have some false positives which will move in the other direction. Now, you'll notice that there are fewer patients with metastatic disease in the non-metastatic group, but we dilute the patients, the burden of disease, in the metastatic group. So in fact, what you find is that survival overall improves. So next generation imaging increases the prevalence of metastatic disease, as you can see here, but seems to improve the outcomes for all groups. But overall survival for each individual patient is not improved because we didn't change the treatment in response to the new classification. So to improve overall survival, next generation imaging must alter therapy depending on what the next generation imaging shows you. But the problem is that clinicians don't know how to use next generation imaging for patient management because therapy approvals are linked to assessment methods, which tends to solidify practice, and this often leads to inappropriate or even off-label uses of diagnostics and in fact of treatments. In the setting of therapy response, conventional imaging doesn't give us a good idea about who is not benefiting from therapy soon after starting treatment. And this impedes patient progress to alternative therapies, increasing costs and toxicities without giving you benefits. And this applies for both CT scans and to bone scans. So for CT scans, we know that CT scans are considered non-measurable, We know that marrow infiltration can occur without altering the calcified matrix, and even if we see something in the matrix, it's difficult to distinguish sclerotic progression from a sclerotic response. And one of the most important things to remember is that there are only progression criteria for CT scan. There are no positive benefit criteria. So let's look at this 86-year-old man with castration-resistant prostate cancer. He's being treated with an immunotherapy, pembrolizumab, and a PARP inhibitor, olaparib. We can see that we were blinded to his PSA. There's clearly sequelae of previous therapy in the spine. You can see how over time we call this completely stable on RECIST criteria. But he was clinically progressing, taken off the clinical trial. We unblinded the PSA, and you'll notice it's 401. So although we had called this stable, he was clearly progressing, and you can see this on the whole body MRI scan. This is one of the major problems that occurs with CT scans. And similar but related problems also occur with bone scans when assessing therapy response. We cannot, using bone scans, distinguish rapidly between people who are progressing and people who have pseudoprogression, as a result of which we use something called the 2+2 rule. We know that there is a high frequency of progression without bone scan changes, which leads to poor outcomes. But we also know that if you only have a single lesion that progresses, or you have a lesion that becomes larger, then that is not counted as progression. And in fact, patients with superscans are excluded from oncological trials. And just like in CT scans, there are progression criteria only. There are no positive benefit criteria. Let me just show you an example. So here's a man receiving enzalutamide for castration-resistant prostate cancer. We see two lesions in the red arrows in the right-hand panel, and you can see that the sternal bone lesion is also larger. Now this is a new lesion on the first follow-up scan, but what is this? Well, this could be true progression. This could be something called tumor momentum, a temporary worsening of the disease before the cytostatic androgen withdrawal response kicks in, or this could be response. In other words, something called bone scan flare or even pseudo progression. So to get over the bone scan flare phenomenon, we apply the 2+2 rule. That is to say, if we see two lesions in the first follow-up period, then we need to see two more lesions on the next follow-up study. And if we apply this rule, you can see what happens. Over time, these lesions fade away, and clearly he responds to therapy. The question we need to ask is how reliable is the pseudoprogression bone scan flare phenomenon to tell us that in fact this is response. It turns out that in first line therapy it is reliable, in second line therapy it's not. And this is the problem with the bone scan flare phenomenon. So we can apply the 2+2 rule, or we can use clinical assessments such as PSA and morphological CT scans to tell us what's going on. The problem is these tools also don't give us an accurate readout. So for example, in the hormone-sensitive prostate cancer state, we know there's a discordant between clinical and radiographic progression in about 30% of cases. And in castration-resistant prostate cancer, we again see that there is a discordance between radiographic progression and clinical PSA progression. And it's in this context that we need to think about functional imaging, not only for characterization, as we've just discussed, but also for response assessment settings. And whole body MRI is a way of evaluating both the bone and soft tissue disease because it assesses tissue cellularity and cellular viability. So it can be used for disease detection, but also for therapy assessments. There are multiple advantages, such as a standardized technique, potential wide availability, no injections required, quick to perform, and in fact reasonably quick to read. We know from multiple studies that the lower the ADC, the higher is the cellularity, The higher is the signal intensity, the higher is the cellularity, and the lower is the fat fraction, the lower is the cellularity. And in fact, the change in ADC tells us something about cellular viability. So as you kill cells with therapy, there is a shift of the histogram to the right, and this is what you observe here and here. So this is a man who was treated with docetaxel, ADT, and prednisolone with hormone-sensitive prostate cancer, and you can see how we have segmented out the disease before and after treatment, and you can see how there's a shift to the right. Now it's possible to spatially back map habitats that are observed on the ADC map. So tumor cells that are killed would be colored green. Tumor cells that are alive are colored red. And if we just magnify this, we can identify that in this particular man, before treatment, all the cells are red, and after treatment, you can see these residual red areas where there's no treatment effect. The green areas represent ADC values greater than 1500, and the yellow areas are in between. So no treatment effect, likely to be responding, and highly likely to be responding. Now, this is exactly what we expect because we know that clonal evolution occurs leading to therapy resistance. And if you use this technology, it's very, very common to see areas of resistance developing very early after chemotherapy. So how do we do whole body MRI scans? Well, whole body MRI scans can be done by using two protocols, the core protocol and the comprehensive protocol. Core protocol is used for lesion detection and characterization. It includes a sagittal T1, a sagittal stir, an axial or a coronal T1 Dixon technique, diffusion sequences with just 2 B values, and that should take you about 1/2 hour. So here's a core protocol as applied to prostate cancer, and here's a core protocol as applied to multiple myeloma. T1, stir, the B900 diffusion image, and if you take a section at the level of the mid pelvis, you can see here is the axial Dixon technique in phase, opposed phase, fat and water images, and you can see a mandatory reconstruction of a fat fraction image. And this is the B50, the B900, and then the mandatory reconstruction of an ADC map. So you can see that there are two quantitative parameters that can be derived in a core protocol. In the comprehensive protocol, we extend the protocol. So not only do you do axial, but you also do coronal in 2 planes, Dixon techniques. You can see that we use 3 B values, and there is the possibility of using small field of view images to also look at other areas. Of course, you can also observe that you do an axial whole body T2 sequence for anatomical localization. And here is a typical example. Sagittal stir, a sagittal T1, a coronal Dixon technique with fat fraction. Here is the axial fat fraction. Here is the T2 sequence. Here's the high B value image and the ADC. And this is the MIP image of the high B value image. And you can see that there are possibly 2 abnormalities here and here. Now it's possible just to look at the raw data or to do small field of view images to these areas to see what these abnormalities are. And you can see this thoracic abnormality in fact is just an area of fat poor bone marrow, whereas the small field of view images of the internal iliac regions shows the presence of extranodal disease from a metastatic internal iliac lymph node. We almost always do a UTE sequence, usually in the coronal plane, in a breath hold to show the presence of metastatic disease, and that seems to work quite well. But we also, on a routine basis, would do a fast flare sequence. Usually it takes 1 to 2 minutes to look at things like osteonecrosis of the jaw. You'll notice that we do not apply a fat suppression on the fast flare sequence. So we can see the signal in the jaw. And of course, if you see something, you should give contrast to see what that is. And in this case, this is a metastasis. So here is the core protocol and the comprehensive protocol just displayed as one table, so you can have an idea of the comparison of the two techniques. So what are the indications for whole body MRI? The International Myeloma Working Group in 2015 and its most recent update in 2018 suggested that you could use a whole body MRI for diagnosing symptomatic multiple myeloma. In fact, they suggested that you should use low dose body CT scans before doing a PET scan or a whole body MRI. What they said was that there had to be clear evidence of osteolytic bone destruction, in other words, a lesion more than 5 millimeters in size, to be seen on the CT component of the PET scan or on the low dose body CT. However, you did not need this on the MRI scan. On the MRI scan, you needed more than one unequivocal lesion that was more than 5 millimeters in size, and that would be considered as meeting the requirement for symptomatic disease, so you could start treatment. However, they did say that diffuse disease seen on MRI would require confirmation using a trephine biopsy. And it turns out that there are about 10% of people who have a positive whole body MRI and a negative FDG PET scan, which is related to downregulation of the hexokinase 2 enzyme that results in this disconnection between what the PET scan shows and what the whole body diffusion scan shows. So here is an example of somebody that we diagnosed using a whole body MRI scan with a plasmacytoma. And the question was this multiple myeloma? And the answer to that is no. This is a plasmacytoma. This was biopsied using the whole body MRI information, given radiotherapy, and then as we followed the patient with the rising tumor markers, you can see that there is the emergence of the symptomatic myeloma phenotype with multiple new lesions. But there are also multiple indications in breast and prostate cancer. The most commonly used reason for it is the equivocal bone scan or CT scan, as I've already described, for both breast cancer as well as for prostate cancer. And that's because of the high sensitivity of whole body MRI compared to the bone scan. So if you look at these ROC plots, you can see that for prostate cancer, certainly, the whole body MRI and in this case the fluorocholine PET CT outperform the bone scan. And you can see that in relation to FDG PET scans also. So here is the performance of FDG PET scan, here's the performance of MRI, and here's the performance of the bone scan. And we can leverage this sensitivity to be confident that there is no other disease that is macroscopically detectable to identify an oligometastatic deposit like this, which we can then irradiate. And although there's no morphological change, you can see that there is a functional response on the MRI scan. Another use for whole body MRI is in women who develop arthralgias when they are on aromatase inhibitors. And here is a patient that I saw recently. You can see there's no evidence of metastatic disease, and this high signal corresponds to an area of radiation damage to the lung, and you can see the high signal on the ADC. We also use whole body MRI when you have patients with high risk locally advanced breast cancer. And here is an example of a 38-year-old woman with a high risk locally advanced breast cancer, which is ER positive. You can see the CT report. It says, to my eye, no convincing sternal, right acetabular, or T12 vertebral lesions are identified. However, the bone scan shows some increased uptake in these areas, and I suggest you do either a spinal or a sternal MRI scan for reassurance or a whole body MRI scan. And in fact, this patient had a whole body MRI scan. And it's really surprising to see how much disease we see. On the T1 sequence, for example, we see no normal bone marrow. But notice the advantage, a locally advanced carcinoma of the left breast with axillary lymphadenopathy, diffuse metastatic disease throughout the skeleton, and here is the ADC histogram with a mean value of 761. Now let's see what happens to this patient when the patient is treated. So the left two columns are before treatment, the right two columns are post 2 cycles of palbociclib, letrozole, and xalendronic acid. You can see on the T1 there is hardly any change. On the T2 it's also difficult to say what is going on. So you'll see the prior exam on the bottom row and the current exam on the top row. And you can see how the ADC value has dramatically increased, although we did not see anything on the T1 or the stir sequence. Again, multiple lesions are being pointed out that show you how the ADC markedly increases. And you can see on the whole body MRI scan on the right hand side that there is in fact a decrease in the signal intensity of the. Now I just wanted to show you how we calculate or how we do the segmentation of the whole body MRI scan. So here is the diffusion sequence which is being segmented on the basis of signal intensity, and then we are using a punch tool to remove what we think are normal structures. So for example, the kidney will be removed. Here we can see the bowel loops and the left kidney are then removed, followed by the spleen, followed by the head, and then we will tackle the axillary lymph nodes first on the right and then on the left. You can see we're also taking out the supraclavicular fossa lymph nodes. Once we are happy with this, we can plot the histogram for the segmented bone marrow, and you'll see the histogram appearing on the right hand side, and then we will move to do the post-treatment scan. So here's the post-treatment scan. You can see how I'm adjusting the window initially, applying the same threshold, and you can see that we get less bone marrow on this particular occasion because the signal intensity has dropped. Again, we remove the head, the responding disease in the left axilla. We will then remove the kidneys. We're almost done. And then we can do the bony pelvis. Now we need to segment about the same amount of bone marrow as we had before treatment, and we'll do that by altering the signal. And when we do that, you can see we've got about the same amount of bone marrow as we had previously, and then we will plot the histogram. And the histogram will appear on the top right-hand image, which will show you a rightward shift of the bone marrow disease, and this represents tumor cell kill. So how effective are we at evaluating metastatic bone disease in breast cancer? Recently, we published the RESPECT study where 43 men with metastatic bone-only disease were evaluated by 12 weekly CT scans, MRI scans, clinic visits, and blood tests, with the CT scans and the MRI scans being reported independently. 33 women developed disease progression requiring a systemic anti-cancer therapy change. We found that 2/3 of women had progressed only on the MRI scan, whereas 1/3 of women had progressed both on the MRI scan and on the CT scan, and no patients had CT scan only progression. When we knew patients were progressing in the bones, 50% of these women did not have disease progression detected on the bone scan. Here's an example of one of the patients that we had. You can see this patient is a 59-year-old being treated with hormonal therapy, and you can see that she progresses between August 2016 and February 2017, and here are the raw data for the high B-value image, and that's clearly progression. If you look at the corresponding bone scan, you can see that the bone scan reported disease extent unchanged with no increase or decrease in the volume of disease. And if you look at the CT scans, you can see there's some increase in sclerosis, but I don't think any of us would have said that this is so much of a change that this would require a change in therapy. Okay, so we now have learned that we can use it for response assessment for bone-only disease or bone and liver disease. But we can also use it to monitor those difficult areas to evaluate, such as cutaneous recurrences, pleural disease, and pseudocirrhosis. So here's a patient with ER-positive breast cancer before and after fulvestrant, and then before and after capecitabine. You'll see on the CT scan, we can see that the patient is clearly progressing, and here is a metastatic deposit that has emerged in the liver. But it's very difficult to see the bone invasion here, but it is evident, in fact, on the whole body MRI scan, and you can see that we see more liver metastases on the diffusion sequence. Now, it's possible to just segment this disease to get volumes of the disease distribution. So you can see that we went from 165 ml to 531 ml to 794 ml of cancer. And if you look at the histogram on the right, you'll see that the ADC did not change between examination of 1 and 2, 2 and 3. And no change in the ADC, but an increase in tumor volume is quite a common pattern for disease progression. Now, how do we begin to standardize the response assessment for bone disease? And this is where the Metries criteria come in. The Metries criteria were developed to objectively assess the response of metastatic disease on whole body MRI scans, giving response assessment categories. Response assessment categories were one of 5 categories in 3 groups. So response assessment category 1 and 2 represented highly likely to be responding and likely to be responding. Response assessment category 3 represented stable disease, and response assessment category 4 and 5 represented progression likely and highly likely. And this is the threshold that we used in the RESPECT study to say that a patient was progressing. So what are the criteria for response assessment category 5? You can see the pictures here and the words here. So an unequivocal increase in number and size of lesions, the evolution of focal disease into a diffuse neoplastic process, the appearance or increase in soft tissue disease associated with bone disease. So all of us would agree. But look at the diffusion criteria. There's only one diffusion criteria. The ADC value should be in the active range. And this is what we talked about previously when we were referring to that patient with pleural disease. So here's a patient who has developed primary resistance to androgen deprivation therapy. You can see the emergence of new lesions. You see the enlargement of previously noted disease. You can see an increase in tumor volume. However, look at the ADC. The ADC does not change. It increases from 840 to 930, which is not statistically significant. However, for response assessment, we use both morphological criteria as well as diffusion criteria. So response assessment category highly likely is return of the normal marrow in previous areas of infiltration, a decrease in the number and size of lesions, a decrease in the soft tissue associated with bone disease. But you'll also notice that there are 2 ADC criteria. So an ADC that starts below 1400 and becomes more than 1400, or even a 40% increase in ADC from baseline values. So here's the same patient that I showed you previously with hormone-sensitive prostate cancer receiving docetaxel, an LHRH agonist, and prednisone. And you can see how the signal intensity decreases on the high B value image, But if you look at the T1, it might even look worse. And we can see that the soft tissue within the canal has disappeared, but the T2 is otherwise difficult to interpret. And here are the images that I showed you previously. You can see how the ADC increases, and we can read off the increase in ADC that increased from 705 to 1529, and you can see a widening of the standard deviation also. Here's a woman with metastatic breast cancer before and after 3 cycles of capecitabine chemotherapy. Is this patient progressing? Is she stable, or is she responding? If you look at the T1 sequence, you might be tempted to say that she was getting worse. The T2 is a little more confusing. What are we going to say? Progression, stable, or response? We can see on the histograms that this patient has clearly responded. This is the pre-treatment histogram, this is the post-treatment histogram. You can see the shift to the right-hand side. And looking at the raw data, you can see that the liver disease also gets better. So this is an example of a good example of responding disease using ADC criteria, but not morphological criteria. And here again are the histogram statistics. You can see that the ADC increases from 904 to 1300. We can see that the standard deviation increases, the kurtosis decreases also. And if we follow her further, we're still more confused, because on morphological sequences we see nothing on the T1. On the stir sequences we continue to be confused. However, if you do the histograms, you can see that the histogram begins to come back. So this is pre-treatment, this is post-treatment, and this is the follow-up, and you can see how there's a new peak that's appearing, but you'll notice this peak is below this peak. And what does this new peak represent? This new peak represents fibrosis, dehydration, the return of marrow fat. So what we've got to realize is that this is a dynamic process, that as you treat, ADC normally goes up and then begins to come down, although it's not unusual to see a process like this where you don't see an increase in ADC, but you just see the reparatory process occurring. So you can see how we've also now changed the paradigm in the response assessment category assessments. Traditionally, we would divide patients into progression or non-progression categories. Now we have a very much more nuanced way of saying whether somebody is responding or not using functional imaging. So you can see how we've completely changed things, not only for disease detection, but also for response assessment. And there are multiple physician barriers that have now emerged as we've started introducing next generation imaging. There is a resistance amongst clinical colleagues to changing the staging paradigm despite acknowledging poor sensitivity and specificity of conventional imaging. Remember that there are economic forces that stop you changing the paradigm. Next generation imaging is said to be nice to have, good for teaching hospitals and the big cities. Clinicians also don't know what to do with next generation imaging technology because, as we've already said, therapy approvals are linked to the assessment methods, thus influencing clinical practice. And of course, we have changed the perspectives, not only on disease prevalence, but also on natural history. We've caused stage migration, and we didn't even talk about lead time and length time bias. So here are my concluding remarks. We can certainly say that bone scans will be replaced by some sort of next generation imaging technologies, and whole body MRI scan is one such disruptive technologies. I think CT scans are here to stay because the matrix is well depicted. There's a real potential to alter diagnostic thinking when assessing bone disease response also. And technologies like these open up bone disease to precision oncology developments. which, as you know, is to give the right treatment for the right patient at the right time for the right duration to keep patients as well as possible for as long as possible. However, we continue to need to do further studies on detection and response where we take and mitigate for stage migration, response migration, lead and length time biases. I hope you found this useful. We can discuss questions at your convenience.